So I thought I'd cover, first of all, the background, then talk about some of the current theories. If we have enough time, we can do a few cases. I'll go over some common questions that I get asked, and I'm sure everyone here has been asked at some point, and then go through some tips and tricks and some resources. So essentially IBS, as we all know, it's a functional GI disorder, abdominal pain in the absence of any mechanical, inflammatory or biochemical diseases. It's often classified into IBS-C, which is IBS constipation predominant. D is obviously diarrhea predominant, M is mixed, and U is sort of unspecified. Unfortunately, there's no, which kind of is a big umbrella term which encompasses everything, doesn't it? There's no definitive investigational biomarker for this. The studies have said in the Western population it can affect between 10 and 30% of our population, so I'm sure everyone here has got patients with IBS. Predominantly female of a younger age group, and obviously has a significant impact on quality of life. Earliest reports of IBS date back to the 19th and 20th century. Back then it was a diagnosis of exclusion, so after they'd ruled out malignancy, inflammatory conditions, infectious diseases with full investigations, often extensive and unsuccessful surgeries, then they sort of said maybe this is IBS. Still, back then was frequently misdiagnosed, poorly understood. So in 1978, Manning came up with some criteria looking at IBS, and since then they've formed this working group, the Rome criteria, which is probably what people have heard of before. So as you can see there on the timeline, it goes through what's developed and what's happened in terms of studies and our recognition and understanding of irritable bowel syndrome. So Rome 1 criteria was first made back in 1994, and sort of we're up to Rome 4 now. And as you can see, more authors, more countries, and more pharmaceutical agents are involved. More studies have been directed towards it. So at the moment, Rome 4 criteria for IBS, so essentially they've classified it as abdominal pain, on average at least 1 day per week in the last 3 months, with 2 or more of the following criteria. So related to defecation, so can have pain before or after defecation, change in the frequency of stool, and a change in the form. So this kind of goes through our understanding and our appreciation of exactly what is contributing to IBS. So initially, in the early days, we thought it was more along the lines of a motility type problem, but as time's gone on, we've appreciated more that visceral hypersensitivity probably plays a part in it, post-infectious IBS phenomenon, obviously diet, gluten, probiotics, antibacterial use, a bit of everything really. So proposed pathways, which I think we probably, most of us will have seen in our practice. So it might be the setting of someone who gets acute gastroenteritis, and then from there they struggle with post-infectious irritable bowel syndrome, and it's probably a combination of visceral hypersensitivity, altered gut microbiota, stress, diet, the works. So, yeah. I've done a few cases, but maybe I'll flick through those and we can come back to them at the end. So in preparing this talk, I had a chat to one of my friends who's a GP and said, what would GPs like to know? And he said, what are the common questions that you get asked and how do you answer them? And probably one of the most common questions that I get asked is, what food should I eat? And probably about 5 years ago, people used to come to me and say, what about this paleo diet? And then maybe 3 or 4 years ago, the Candida diet was sort of in phase. Then this juice cleanse and liquid diet type phenomenon, not alcohol liquid diet, but juice liquid diet. Should I go vegan or vegetarian? Should I go gluten-free? Should I exclude this, exclude that? Should I go down the line of coffee enemas? I said, no, probably should drink coffee, not really use it as an enema. Or low FODMAPs. So I'm sure everyone's been asked this at some point. Would that be correct? Yes. I guess the response that I would say is it depends on what symptoms you're trying to alleviate. And the one diet that does have the evidence is the low FODMAPs diet. So that was done, this is based on the study done in Monash, so our colleagues over in Australia. So the blue line is the low FODMAPs diet. So the first slide on the left there is the IBS patients. And so it's comparing their diet when they've gone from beforehand in the red to afterwards. So the typical Australian diet is the yellow line at the top, and you can see that they did get significant improvement in terms of bloating, pain, and wind symptoms being on the low FODMAPs diet compared to the healthy controls. So that's the one that does have the evidence. So there is obviously multiple resources online that you can look at. So this is a sheet that I'll often print off for patients to sort of provide a framework as to what they can work on. Obviously it's not hard and fast, and it's not meant to be strictly adhered to, so they sort of need to do it for a 6-week period. That's what the time that the study was looked at, and so they initially go load for FODMAPs, and then they start reintroducing the other food groups back in and see how they respond. So a dietitian input is often very useful in this situation. One of the other questions that I get asked a lot is, should I be taking probiotics? Have people been asked that? So this here is from the American Journal of Gastroenterology 2018, so it's a multi-analysis of all of the studies looking at probiotics and whether they're effective and which ones are effective. And essentially the long of the short is there isn't really in adults an answer. So some of them say yes, some say no. There are specific groups of patients which tend to be sort of the ulcerative proctitis and pouchitis that will improve with VSL3, which is one of the probiotics that you can buy, and I used it when I was in the UK. But in saying that, for IBS there isn't a hard and fast, and I've got patients who say yes, it helps them, and others who say no, it doesn't. Maybe some of that's placebo, maybe some of it's true effect, but yeah. Another question that I get asked quite a lot is, why do I always need to go to the toilet after I eat? Is that just a question that I get asked, or does everyone else get asked that in IBS patients? Essentially, it's the gastrocolic reflex, and in IBS patients, as you can see here, so the IBS group are the yellow group. You can see if they're fasting, they get higher waves in their colon. After a meal, it's significantly higher, and with cholecystokinin, it's higher. So they do have that propensity for after they eat, they suddenly need to rush to the toilet. So it is a phenomenon that we see in IBS. And then another question that I get asked, admittedly this was first from my nephew when he was about 6 years old, where do farts come from? I'm just glad that it wasn't followed up by where do babies come from? Probably not my area of expertise, but I have been asked it by patients as well. So essentially it's bacteria in the colon fermenting and producing gas. Normally we make about 500 to 150 mils per day. It's a bit of pub trivia knowledge for everyone. And we do pass probably about 14 times a day, maybe between 25 and 100 mils. IBS patients actually produce the same amount, but are just probably more sensitive to it is the theories or the thought process behind it. So this is one of the books that my nephew loved reading when he was younger. So I kind of feel like it's a low FODMAPs kind of teaching point. Essentially, it's a book called Dr. Dog, and Dr. Dog goes around talking to the grandfather and says, Granddad, you've been eating too much beer and having too many baked beans, making gases in your colon. And then farted so much he blew the roof off the house. So it kind of is true for some of our IBS patients, I must say. In terms of useful resources, which you can take home, obviously New Zealand Health Navigator has quite a lot of useful resources for IBS, and I think that the booklet there that I've taken a screenshot of, Managing Your Life with IBS, is actually quite a good one. It's about 90 odd pages, and patients can just access it online and read it. So it goes through a whole bunch of stuff about the current theories and about what symptoms they may experience. It talks about medications we give and why we give them, along with alternative and complementary therapies, so acupuncture and yoga and the work. So it really covers everything, and I think it's quite a good resource. The other one that I think is quite helpful is ibsforgps.com. So that's actually an Australian resource, and my colleague who works in Melbourne says it's just been set up this year, and it's quite useful. It goes through a few sort of work algorithms, if you like, and I've taken a few screenshots, so I'll show you that in a minute. And then the Monash FODMAP website is quite good as well. So you can download the app which goes through the food groups, the low FODMAPs food groups, which patients can find quite useful. So this is the IBS for GPs .com, so as I said, it's from the Australian Gastro Society. Treatment algorithms, diagnoses. It's got some patient resources and some also GP resources. So that if you click on the sort of algorithm, that's what it kind of comes up with. So it just refreshes your mind about the warning symptoms, so what things you should be concerned about, rectal bleeding, obviously weight loss, fevers, incontinence, abdominal mass, the works. And then obviously some targeted treatment options, and you can click on those and print them off for patients. Okay, should we go back through a few cases and maybe get a bit of audience interaction? Okay. So I picked a few cases that I've seen in the last few weeks. So the first one's a 38-year-old female. She's a nurse who works in the hospital. She used to do night shift and work shift work and tells me she had a fluctuating bowel habit. Worse so on night shift. She now works day shift. She had rheumatic fever in childhood. She's paid herself for a gastroscopy and colonoscopy privately, which she thinks about 4 years ago, which were unremarkable, but does have a long history of fluctuating bowel habit, bloating, abdominal discomfort. She tells me, and I quote, that she's not a good public toilet user. To that I said, you're just a toilet connoisseur. Symptoms have been a bit worse recently. She saw her GP and got some blood tests done which were unremarkable. So maybe I can open it up to everyone and say, what sort of things would you suggest or want to do? Change job. a good thought. Would you direct her to the website or? Yeah. So I went down the lines of talking to her about diet. So low FODMAPs, talked to her about fluid and fibre, suggested a bulking agent, spoke about antispasmodics and possibly some tricyclates. So I saw her a couple of weeks later and she actually was quite well and she was happy just drinking a bit more fluid, sort of looking at her diet, and she tried psyllium husk and thought it was useful. So it was quite a straightforward fix, which is good. Next one's a 64-year-old female. She works in admin for a bank. Her background is anxiety, and she also had an eating disorder in the past. She's got hypothyroidism, is on thyroxine and a bit of citalopram. She has this long history of constipation and abdominal pain. She tells me she had a colonoscopy attempted many years ago, but she said the prep was poor. She was brought in, she was made to drink more, she just couldn't get through it. They tried, didn't have much luck. Essentially, her symptoms have gotten worse and they're impacting on her ability to function at work. She says she sits at work during the day and then doesn't really eat much. By the afternoon, she's sort of snacking on lollies, and then she's starting to feel bloated and often has to rush to the toilet and then go lie down and can't really function. Her blood tests are normal. What would people do here? Refer, okay. It's fine. Essentially, I had a long chat to her, and stress was a significant part in her symptoms, and she said at work she felt stressed out and was under pressure. But when she went on holiday, everything sort of eased off significantly, and she was going to go and see a psychologist about her issues with past history of eating disorders and her thoughts around food and diet and everything like that, but was more keen to go down the lines of complementary therapy. So she said to me when she was pregnant she'd had quite a lot of success with acupuncture for morning sickness, so was quite keen to go down that pathway. Next one is 61-year-old female. She has a long history of what she says to me was bowel issues, and that emotions are loose. She has urgency and tenesmus. Before she goes to work, she goes 3 to 4 times, and then once she gets to work, she goes 2 or 3 times. She's trialled probiotics with some improvement. Of note, her family history includes that her maternal grandmother had ulcerative colitis. Her GP sent off some blood tests which were unremarkable, and stool tests which didn't show any bacteria or pathogens. What would people do here? Colonoscopy? Yes. Yep. Yes, that would be helpful. So she hadn't had a calprotectin done, but I saw her and I had a chat to her and said, oh, yes, we were going to need to do a colonoscopy. But in the interim, I suggested that she try low FODMAPs type diet and a bulking agent. So when I saw her for the colonoscopy 2 weeks ago, and she already said to me just going on a low FODMAPs diet, her symptoms had improved significantly, and that she was able to get to work and wasn't feeling like, oh my God, where's the toilet on the way? And her colonoscopy was actually normal, which is a great result. So she is IBS. ultimately, but I agree she did need a colonoscopy to determine that, so her biopsies were normal. Last case that I've got, I think we're finishing just on time, 65-year-old female. She's got a background of having had radioactive iodine for toxic multinodular goiter. She's got asthma. She's got 1 to 2 month history of loose bowel motions going between 3 and 10 times a day, no blood or mucus. She says to me, could this just be due to diet? I've been eating quite a bit more pineapple recently. I don't know why she said pineapple, but anyway. She's been taking loperamide so she can function at work. She works at the university. Blood tests, again, unremarkable. Stool specimens didn't show anything, and she did have a calprotectin level done, which was normal. So what do we think is going on here, and what do we think needs to be done? Yes. So her story is... quite sudden onset of change in bowel habit. So she got her colonoscopy. The endoscopic appearances were actually normal, but this is her microscopic appearance. So essentially what it shows is collagenous colitis. So that's the collagen membrane there, which is larger than what it should be. So I've put her on some budesonide and she's feeling much, much better. Okay.